several conditions with several different types of doctors. I have a rheumatologist, a gynecologist, a endocrinologist. So in going to all of those people, most of my doctors were in the same medical system. My primary doctor, unfortunately, was not. So I don't think I realized how important it is to have that consistency of everybody being on the same page. And again, this is going back maybe, I don't know, 10 or more years, maybe a little less. My blood pressure was up and my rheumatologist expressed concern. And I would go to my doctor and his physician's assistant would say, no, it's fine. My endocrinologist was concerned. And again, so it kept happening. And so prior to going on a new biologic, I knew one of the side effects was going to be increased blood pressure. That was a risk. And they had talked to me at my rheumatologist office about that being a risk. As a result, I made an appointment to try and be proactive. I met with my general practitioner's physician's assistant because I couldn't get in to see him. And he basically said, if we put you on any more blood pressure medicine, you will pass out. So I left feeling very defeated, and I left feeling sure that I was right, that there was a problem. And I was very defeated in the sense that he didn't hear me. But I'm not a professional. I'm not a medical doctor. I'm not a physician's assistant. So I trusted him. I had been with the practice for a long time. Well, the day I went in for the infusion, my blood pressure was 160 over 110. And my rheumatologist, who I swear is my angel, literally, I'm in a building where there are several specialties, and she took me by the hand and walked me next door to the cardiologist. I realized in that moment, although I liked my general practitioner, I needed everybody to be within the same system. So having that idea of a home, I changed general practitioners. All of my doctors are in the same system, and I'm lucky. I'm near a major city, amazing hospitals. There's teaching hospitals, so we have a lot of research going on. We have a lot of stuff that happens in this area. So I'm one of the lucky ones, and I'm very aware of that. But I think, like I said, if I go and tell a doctor that something's really wrong and I end up in the hospital as a result because what I said wasn't listened to, then you're not going to be the doctor for me. And unfortunately, I did end up in the hospital, and it was a very serious situation, and I had some permanent damage from that. So I've learned, and through that tried to express to other patients, that you really have to advocate, because I think, like you were saying, there's different expectations when a patient goes to a doctor as opposed to when a doctor walks in. And I think when, a lot of patients get nervous, there's the whole white coat syndrome. And that's what I was told for the longest time was the reason why my blood pressure was so high. My general practitioner's person kept telling me, oh, you have white coat syndrome. You just get nervous when they take your blood pressure. So again, we've already talked a little bit about the goal that, our doctors have when we walk in versus the goal we have that we walk in. Is there any way that we can maybe pull them together a little bit more? Any suggestions? I know through my blog, I've written down, you go to the rheumatologist, you might not be flaring. You look great. Your blood work looks great. So document along the way. I take pictures of my joints when they swell, because sometimes I can't believe how bad they are. I write down the days that I don't feel well. I try and give her as much information as possible because she insists I don't complain enough. And I insist, I'm like, oh, it's not that bad. But yet when they see me and my joints are so big, yeah, it does get that bad. So I think that communication piece is really, really key in knowing what to sort of talk about. My doctor and I have a really good relationship. I always tell her she's never allowed to retire or leave me. Because my last one did retire and left me. And it was a struggle, as Tiffany said, trying to find somebody. I also had someone who told me there's nothing wrong with you. And I said, oh, well, if there's nothing wrong with me, why are all of my joints swollen and red? And he said, I don't know. I was like, okay, well, you're not the doctor for me. But again, none of us really want to have anything wrong with us. So the talk about, none of us really want a diagnosis, even though we do want the diagnosis. We just want to know what's wrong with us. We want to be able to explain it to other people. And I think the social piece with friends and family is, since we can't always explain what's wrong with us, it's hard for them to understand maybe what we need. And I think that is a piece. Dr. Kim, do you have anything to add
Yeah,
to that?
I think you bring up something very that's really challenging for physicians. Is that so? Particularly in psychiatry, in rheumatology, and also other disciplines where we have to. So I think the toughest job that we do is that we have to take the colloquial coming from the patient, translate that to technical, so that we can apply what we've learned medically, which is taught technically, and then translate it back to colloquial to be able to have you guys as patients understand what the full intent of what we mean. And oftentimes that skill is, I think, oftentimes implied that it's going to occur during medical training.
Oh,
And,
no.
you know, I can't actually think of any work that we've done when I was in medical school or even residency where we actually talked about when a patient says this, how are you interpreting that, right? And I think this also goes down to how good of a physician that he or she is being able to say, you know what, I need to work with much more granularity on what was just said in order for that piece of information to be actionable, right?
Okay.
And I don't know, I don't know how well this is done globally by physicians. I think this is something that I sometimes see some of our, especially young residents, they interpret what the patient says the way they want it to because they're time constraints, right? And sometimes you have to back up and say, listen, I'm not actually 100% sure that's what they meant.